Good afternoon, everyone. Welcome to our webinar today, 7 Things to Know About Practicing Medicine in Texas, Part 1. There will be a Part 2 of this presentation. We thank you for taking time from your busy day to join us for today. Before we get started, just a few housekeeping items to let you know about. This presentation is being recorded, and you will get a link to the recording after the presentation is concluded. There are also a couple of files for you to download as resources. If you would like to do that, you'll see a files pod there that says 7 Things Webinar Part 1 Final and an Adolescent Health Guide. Those are for you to download if you would like to do that. And for today's presentation, we just wanted to let you know, we realize that some of you joining us today are not clinicians, are not advanced practice providers, and we do hope that you still find this information valuable and possibly a helpful tool as you onboard new clinicians to your practice. So today the presenters are Cassie Turner, I'm the manager of TMLT Risk Management, and Kathy Bryant is also with us today. She is the manager of TMLT Consulting Services. And our objectives for today, and hopefully some things that you can take away, are being able to identify the relevant rules for medical record documentation. We know that this one is a bit weedy, but we hope that we can share some helpful tools as takeaways. Discussing when to query the Texas Prescription Monitoring Program, and describing the rules for treating minors in the state of Texas. So with that, Kathy, I will turn it over to you for a few introductory remarks.
Thanks, Cassie. We know that there are thousands of rules that cover how you need to practice medicine in Texas. And we're not, excuse me, we're not going to cover thousands of rules. In fact, we hope we can cover 7 rules in today's webinar and the October webinar. The first one is the Texas Medical Board, which I may refer to occasionally as TMB, is probably the the basic rules you need to know if you're a physician or you manage a physician practice here in Texas. So this particular rule covers the elements that are required for a medical record. Now, I know what you're thinking. You pay a lot of money each month for your EHR. And doesn't that make sure that I meet all the requirements of the documentation rules? And yes, that should meet all the requirements, but a lot of it depends on how you actually use your EHR. The developers of EHRs are really not the bad guys. They try to give you some options, if you will. And unfortunately, some of those options can improve your documentation, and some of them may actually hurt your documentation. For example, a lot of the EHRs have a single checkbox where you can mark all systems normal or abnormal. If you mark everything normal, but the patient came in with a significant complaint, you're going to have some mismatch in your documentation. And I know you're crunched for time. There's too many things to do and too little time to do it. So we hope that this webinar will give you some input into not only how to improve your documentation, but to demystify these TMB rules. And I will tell you that when I started at I'm sorry, not TMB, TMLT, I actually bookmarked Chapter 165 of the Texas Medical Board rules because I was referring to it so often. So let's look at the very basics. Number 1, the documentation of each patient encounter should include the reason for the encounter, the relevant history, the physical examination findings and prior medical test results, an assessment, clinical impression, or diagnosis, a plan of care, and the date and legibility or legible identity of the observer. Now, we can thank EHR for that one. It's always going to record the date of the documentation and it's going to be legible. You are also supposed to include or make sure that past and present diagnoses should be accessible to treating and or consulting physicians. The rationale and the results of diagnostic and other ancillary tests should be included in your medical record. Patient progress, including how they're responding to treatment, or if you need to change a diagnosis, that should all be documented, as well as relevant risk factors. The written plan of care is very important because if for some reason you aren't the next provider or that sees the patient, this is going to give whoever sees the patient on your behalf next some insight into what exactly is what your thoughts were, what your treatment and medications were, referrals, patient and family education, and specific follow up instructions. Again, for the last two, EHRs have actually helped us out because EHRs have a lot of built in patient education that can either be printed separately and handed to patients or certainly included in the post visit follow up. Number 7 of the requirements is that you include written consents for treatment. And so that one's typically done one time the first time you see the patient, or a written consent for surgery. So if you're planning surgery after you've done the risks and benefits consultation with the patient and their family, then typically you get assigned consent. And all of those should be included in your records. And last, I would just mention that there is a relative newcomer to the consent world. It's the telemedicine consent. And Cassie's going to talk a little more about that one. Cassie, I think you're on mute.
Thank you for that. So sorry. As I was saying, when you could not hear me, Texas law now states that a physician who provides or facilitates telemedicine shall ensure that the informed consent of the patient or their representative authorized to make healthcare treatment decisions is obtained prior to those medical services. So Kathy has included here in this slide a couple of examples, and there's a link there as well for you all to find those resources that are screenshotted there. But the regulations require also that the privacy and confidentiality notices and notices regarding the complaint process for any alleged misconduct are provided to the patient in order for them to participate in telemedicine. As many of you probably know, notice of patient privacy is critical to meeting those federal and state privacy and security requirements, and you will want to make sure that everyone is making a good faith effort to obtain that written consent from the patient, either via electronically or written in the office whenever they're in for an in-person visit. Additionally, the Texas Medical Board complaint process notice, which I mentioned, should also be provided to the patient before making telemedicine consults. This notice may be provided on the website of the clinic or the physician's website, or with other informed consent materials. Again, the TMB, the Texas Medical Board rules indicate that this notice should be provided before the services are provided. And with that link, as I mentioned, there are some rules around that. It should be posted in a prominent location on your website. It can also be in a bill for services. It must be in at least a 10-point font, easily readable, and it must contain the exact language that you see here that the Texas Medical Board requires for that notice. So again, we included the link here for you to check these resources out when you have a little bit extra time. But as Kathy mentioned, this is a newcomer, so we just wanted to mention it briefly with consent, since it is a new requirement. And I'll just mention too, because we do get a lot of questions about out-of-state telemedicine licensure. The takeaway here is to be aware of the other state, even if your patient is only visiting for a short period of time. You want to be aware of what the licensure requirements are for that state. In the state of Texas, you must be licensed to do telemedicine, and it's pretty much the same in other states. So if you're going to venture into those other states, then you'll want to familiarize yourself with their requirements before doing that. So moving along back to chapter 165, and Kathy, I echo that. I had this downloaded to my phone and numerous places so I could keep up with chapter 165, because we do reference it quite frequently, because this is the foundation of what is required for documentation. So the next component of what is to be included in the medical record is any summary of documentation memorializing communications transmitted or received by the physician where a medical decision is made regarding a patient. So now this could include text messages, this could include emails, this could include phone calls, and these discussions may not be just between you, the provider, and the patient, but it could be between their personal representative, a family member, or another physician or another healthcare member who's participating in the care of the patient. So anything, as it says here, that impacts a medical decision, you'll want to make sure that you're getting this into the medical chart somewhere. In our department, we often see after-hours phone calls are something that don't get captured, and those are critical to have a protocol or a method where you're capturing those after-hours phone calls. And if your apps, your emails aren't integrating into your EHR, then that's something also to make sure that are getting captured into the EHR. Again, continuing on here, billing and coding information is to be included in your record. That's not something that we specialize here in our department, but it is something that you must include as far as making sure that the documentation supports those billing codes that you're selecting. And then all non-biographical populated fields in the EHR or in the medical record must contain accurate data and information pertaining to the patient based on actual findings, assessments, diagnostics, assessments by the physician for that visit. So with this, often what we see when we're reviewing medical documentation are things like copy and paste, where assessments and treatment plans have been copied from a previous note and pulled forward, and they haven't been edited. So that's something just to keep an eye on. We understand for some specialties for continuity of care that you like to see that information from a previous note, but there is a caution to not pull that forward and to update it to where it reflects that particular date of service. Also, when this happens, what we see is that the templates aren't being updated, and so then your review of systems and your review of medications or your problem list is no longer congruent with what we're seeing in the assessment and treatment plan. And then we have a study here that Kathy included for us. About 30 to 70% of physician EHR notes have duplicate content, and this is a study that was recently put forward by the Journal of American Medicine, and I believe they reviewed 100 million notes to characterize the prevalence of duplication in EHRs. And their takeaway from the study was just the duplicity of information, as you well know, increases the time to determine which data is accurate, which other data is created down the road, and other notes we see where perhaps a PA will pull from a physician note, or a nurse practitioner will pull from a physician note. So then it creates these errors in multiple documentation notes throughout the EHR. So something, again, just as a caution, in that study we can share with you if you're interested in it. It's interesting what they're trying to capture there. And then additionally, any amendments that are made should be reflected within the EHR, and then any other salient records that you receive that pertain to history, diagnosis, treatment, or progress of the patient should also be included. And I'll let Kathy talk a little bit more about this retention of medical records, but we do get questions frequently about, if I receive records from another physician, should those be maintained in the record? And generally, yes, you should maintain those, particularly if it's a referral, if it's for the continuation of care. And we also recommend that it's evident whoever is receiving that patient into the clinic is reviewing those notes, and that it's evident that those records that are coming in have been reviewed. So Kathy, can you tell us a little bit more about medical record retention?
Sure. Basically, if you think about medical record retention, there's basically two kind of rules that come into effect. There's one rule that covers adults, and the other rule covers minors. So we're going to talk first about adults. The rule is that for adults, all records must be kept for at least 7 years from the date of last treatment, to include phone calls, prescription refills, or other contact with the patient. So if you saw a patient on July 1st of this year, you're going to keep that record for a minimum until July 1st of 2030. A lot of offices choose to keep the records for 10 years because, in fact, uh, many insurances require or have a clause that they can look back for 10 years. And you'd want to have your records, obviously, if you were having an insurance audit. For minors, it's a little trickier. So it is, you have to maintain, or if a patient is younger than 18 years of age when the child or person was last treated by the physician, the medical records of the patient shall be maintained by the physician until the patient reaches age 21, or 7 years from the date of last treatment, whichever is longer. So if you have a patient that um, just turned 18 and they're going to move on to an adult provider, if you're a pediatrician, for instance, then you have to maintain those records for 7 years. However, if you saw a child at birth to, say, age 10, you're going to have to maintain those records if they move on to another provider or another state, whatever reason they're no longer following with you. At age 10, you have to maintain those 11 years till they would turn 21. So again, this is one is a little confusing. Then you also have to think, well, with electronic records, are we ever really going to um, stop using those, or are we ever going to destroy medical records? And that's a great conversation for another day. But basically, one of the ideas of electronic records way back in the beginning was that they would be there forever, and that your medical history would be available to whoever or whatever provider you were seeing later on in life. And just of a note, any medical records that include civil, criminal, or administrative proceedings may be destroyed only after the physician knows that the proceeding is finally resolved. So if you're involved in a lawsuit, for instance, you cannot destroy those medical records, even if it's the 7 years have passed until that lawsuit would be completely resolved. So I appreciate that sometimes this seems like a burdensome requirement, but it's the rule. We get a lot of questions about requests for medical records. Basically, you have 15 days in the state of Texas to actually resolve or to produce those records when you receive a request. The physician, I'm sorry, HIPAA, on the other hand, allows you longer than that. But I can guarantee you that the federal government knows the Texas rules and they will hold you to the 15-day rule. If there is some reason that the physician feels that releasing records would be harmful to the patient, you have that same 15-day rule in which you must put in writing why you are denying the records. Um, and you have to tell the requester how to file a complaint with the Department of Health and Human Services and the Texas Medical Board.
So this topic here can get a little confusing. We've actually done webinars that are solely dedicated to medical record retention and release of medical records and fees that can be charged. And I would encourage you, if you've not heard us chat about this in the past or you want more resources, please go to our hub or reach out to us and we can share some resources that are a little bit more extensive than what we will touch on today. But since the rules in Texas are a little bit different for the release of medical records and fees, we thought we would mention it. If you're going to be releasing to a third party in the state of Texas, these are the basic outline of the fees that you can charge. So paper, a charge of no more than $25 for the first 25 pages and 50 cents per page for every copy thereafter. Electronic, a charge of no more than $25 for 500 pages or less. $50 for 500 pages or more. Hybrid situations, a combination of the fees as set forth in the paper and electronic formats. Other charges, if it's an affidavit request, a reasonable fee of $15 may be charged. A physician may charge separate fees for medical and billing records requested. And this is published in the Texas Administrative Code, which we've highlighted there for you. Again, we get a lot of questions about what can we charge and to whom, and it does get a little bit confusing because the rules are different for what you can charge to a third party versus what you can charge to the patient directly. So when you're looking at fees to charge to the patient directly whenever they're requesting a copy of their medical record, under HIPAA, they recommend a flat fee of $6.50, which is inclusive of labor, supplies, and any postage that you may incur. Administrative and other costs associated with outsourcing the function, looking for records or going to a storage facility, etc. You will have to come up with a chart basically to outline your cost and how you came to that cost and what you're charging to the patient for these records. The OCR would want to see that fee schedule, if you will. So in general, the OCR, who are the enforcers of the HIPAA privacy rules, encourages patient practices not to charge patients for a copy of their records. We realize that sometimes this feels a little unreasonable, and even $6.50 sometimes feels a little low. But again, if you feel that that's not something, a fee that you're comfortable with, you can develop your own fee. And again, there are many resources that we have on our hub, or if you have questions about it, do feel free to reach out to us. It is could be a little bit confusing of how to come up with that fee if you're wanting to charge something other than the $6.50. But again, there are resources available out there for you. So shifting gears a little bit, that was chapter 165, kind of in a nutshell, very high level. Another thing that differentiates Texas in some regard is the Texas Prescription Monitoring Program. We refer to it as the PMP. And this state law requires physicians to check the PMP before prescribing certain medications, opioids, benzoids, you see those there. The review of the patient's PMP prescribing history must be completed prior to each time a prescription is issued for these medications in these particular situations. So if they're going to be prescribed in an outpatient setting for take-home use, from the physician's office, you would want to check it before prescribing. If the patient is in an inpatient setting or this is an emergency room visit, upon discharge is when you will want to check this PMP program to make sure that there's no caution that should be taken with prescribing any additional medications that are listed here. The PMP check, as I mentioned, is not required before an inpatient stay or hospital admission or during an emergency department visit. Again, it's at discharge when that should be taking place. These checks should be documented in the patient's medical record. We do see with a lot of EMR systems now that it's integrated into the system where you can have a little checkbox that shows, yes, I have checked the PMP prior to prescribing or prior to discharge. We see that pretty frequently now, so that's not something that you have in your EMR and something that you would want. You can check with your vendor to see if that's possible to add that to your documentation. There are a couple of exceptions to the PMP check here: prescriptions used for hospice, cancer care, treatment of sickle cell anemia, and then also if for some reason you're not able to get into the system for a particular reason, that should be documented and noted in the chart. These would be one-off situations and not as a standard. But again, if you're having trouble accessing the system and you need to prescribe, then make sure that that's documented into the notes so that you have that to recall. And again, we also included the source here for the Texas, the PMP, so that you can review it if you have additional questions or need additional information if you're prescribing these types of medications. So Kathy, we get a lot of questions, as you all know, in the risk management department about treating minors. So can you share a few tips with us on treatment of minors in Texas?
Sure. Again, this rule is actually outside of the Texas Medical Board rule. So we've given you a link to the Texas Family Code. The Texas Family Code specifies who can actually consent to treatment for a minor and when a minor can consent on their own behalf. There is the second downloadable file is the Adolescent Health Guide, which is actually published by the state of Texas. It is a great resource. It not only covers who can consent, but there are a lot of good topics around treating minors that we felt might be a helpful resource if you don't already have that in your practice. If a parent or guardian is not available to consent for medical treatment, who can give a who can consent on their behalf so you can treat the child? The caveat to this laundry list of who can consent is that unless something has been you've been given an express notice not to accept that. So, for instance, the first one is a grandparent of a minor. If the parent had told the practice, do not accept consent from Grandma Susie or whatever the name would be, then you've been given that express notice. So that would be the kind of thing you would want to note in your records so that you would know that that person could not give consent. They kind of go in not really a hierarchy, but this is just the list: adult brother or sister, adult aunt or uncle, an educational institution in which the child is enrolled, and the school or educational institution has received a written authorization to consent from the person having a right to consent. So most schools, especially with athletics, give out a form saying it's okay to consent to treatment on my behalf. An adult who is the actual has actual care, control, or possession of the minor and has a written authorization to consent. A court having jurisdiction over a suit affecting the parent-child relationship, or an adult responsible for the actual care and control of the minor, as well as lastly, a peace officer in lawful custody of the minor. So then the flip side of that is, when can a minor consent? And again, these are specified very succinctly in the Texas Family Code. A minor on who is active duty with the armed forces in the United States can consent to their own treatment. A minor who is 16 years of age or older, residing apart from their parents and managing their own financial affairs, can consent to treatment. I think this one's a bit tricky for practices because you're going to have to be able to establish that, yes, they're living apart from their parent, and secondly, they're managing their own financial affairs. A minor who's unmarried and pregnant can consent to treatment related to the pregnancy other than abortion, and a minor can consent to the diagnosis and treatment of infectious, contagious, or communicable diseases that are reportable to the Texas Department of State Health Services. A minor who's unmarried but is the parent of a child and has custody of his or her child and can consent to medical or dental or psychological or even surgical care of the child. And a minor can consent to counseling for suicide prevention, chemical or alcohol addiction or dependency, or sexual, physical, or emotional abuse. I know that's a lot of material that we've covered in just a short period of time. Would like to invite you to join us on October 24th, when we'll cover more in depth about informed consent, medical spa regulations, physician advertising, and leaving a medical practice. At this time, it looks like we have a few questions. Um, Before we switch over to the questions, I would encourage you to just, if you have questions, the question pod will still be open, and feel free to continue asking questions as we go along. We want to thank you for joining us today for the webinar. It is approved for 1 credit of CME, including the 1 credit for medical ethics and or professional responsibility. And your feedback is really important to us. When we email you the link for the recording, the CME evaluation link will be included in that email. And we would just ask you uh, to fill that out and give us feedback on today's webinar. You can also expect your CME certificates to be emailed to you in about 10 business days. So the first question is in regard to out-of-state licensure. The question is, do you mean that The physician must be licensed to practice in another state besides Texas. And that is true. If you're going to be doing telemedicine in multiple states, then you need to be licensed in both the state that the patient is residing as well as Texas. The next question is about medical records retention and OB-GYN practices. Cassie, do you want to go through that one? It looks like we have several questions related to that.
Sure. So the question is, how do we follow the guidelines when we chart can include information for both mother and baby? If you have an OB patient, then yes, that's generally what we would see. We would see the OB note that's part of your GYN note, if you will, the flow sheets. That's typically what we see on those OB. And we do recommend that those records are kept for 21 years after. There are a couple of other questions following up for your OB patients. The other part of those requirements we're referring to are minors, primarily in a pediatric practice. But yes, if you're an OB and you have OB patients, then those records we would recommend you maintaining for until the baby has reached 21 years of age.
So on telemedicine, if your patient is a Texas resident and is on vacation in another state and needs a telemedicine visit, can the Texas licensed provider do the telemedicine visit? If and I'm reading into that they are not licensed in Florida. It's my understanding, and Cassie, if you have more recent information, please feel free to add. But it's my understanding if the person is just temporarily out of state, then they can be treated by a Texas physician without a license in that other state.
Yeah, Kathy, that's what I've heard. I mean, honestly, we've heard both sides of the coin, so I would just say be very cautious. And it would be a temporary situation, maybe one time, but if someone's on a very extended vacation where they're needing months of refills or something along those lines, or they're living in another part of the country for a certain period of time, I think then that's when it gets a little bit more challenging to navigate without having a license within that state where the patient is at.
I think a good example that I have heard is that if the let's say the patient is a college student, and so in August of every year they move to Washington State to go to a university, and they're not going to be back in Texas till next May, that would be an example where they would either need to have a physician in Washington, or they need to have the physician in Texas would need to have a Washington license to be able to do telemedicine during the time they're gone.
Great, thanks. Going back, I guess a couple of other questions about the OB-GYN patients and consent for a minor who's emancipated. For emancipation, there's generally some court documentation that's available that you could ask for to confirm that the kiddo has been emancipated from their family. So that's one thing that you could ask for if you were needing it. And then the next question was consent to treat a child, specifically state who can bring the child for treatment. Can the grandparent bring child without written consent in the chart from the patient? We generally recommend that whomever is bringing the patient in for treatment at that appointment, that it's very specific, even down to adding a name when possible, because we've just seen very convoluted situations sometimes where it's really not clear who was with the child when they were brought in. So if it's grandmother Susie, like Kathy mentioned earlier, just getting that specificity and that detail in the documentation is so helpful. And then it's not unclear who it was. So I think, yes, if you can capture that, then it's just very helpful should you need that level of detail.
I'm not seeing any other question. Oh, nope, here comes another question. Regarding amending records, what suggestion do you have as to how long after should we make the correction? Is it ever is there ever a time limit when it's too late to correct? And I would say there's not a time limit. What you need to be sure that gets documented is when you're making that correction that you're dating and timing the date of that amendment. Again, most electronic records will help you with this, in fact, in that they're going to date the time and the actual amendment. Um, I think we're not attorneys, but I think
Mhm.
that most attorneys would agree that if you know there is something wrong in your medical records, um, and that may be because the patient came back a year later and in reviewing your notes, you went, oh my gosh, I didn't mean to say they had a broken right arm when it was their left arm or whatever the discrepancy is. It's better to make that correction and amend the record so it is correct than to leave the error to go on into perpetuity.
So there's another question here about can a minor seek treatment for STD without consent of parent or guardian? Yes, this is one of the exceptions for seeking treatment. And I'll just mention again in the files pod, there's that adolescent health guidance PDF. This is put forth by the state, and we refer to this quite often in our department. It's really a great resource to just refer to if you're having questions of when can they consent to their own treatment, when then can they not, particularly if you're in a pediatric practice or a practice that sees minors routinely. It's a really helpful resource, but yes, for STD without the consent of a parent or guardian. And then Kathy, I'll let you expound on this one regarding unsigned notes. What is the time limit to chart appropriately? Any issues if the provider is consistently guilty of not signing notes? Tools you can direct us to help the provider see the problems.
Well, I actually heard an attorney speak on this topic one time, and they basically said, if you're involved in a lawsuit, you can you or the attorney can explain to the judge and jury that there was an emergency and the provider did not get back to sign their note until the next day. That's fairly easy to explain. Or they didn't finish clinic till 7 o'clock at night and the notes weren't signed until the next day. That's explainable. However, if days and weeks, even months in some cases go by, there have been such examples that we have seen, then that's a whole lot harder to explain to a jury is why the note was not signed for a long period of time. Would encourage the practice to set a rule, whether that's 48 hours, whatever length of time that is, and that if the provider has not signed the note, what happens? And that is something that takes a lot of or discussion within the group, especially the larger the group is. I'm not sure of any tools that can help the provider see the problem other than um, if you have a rule that says you cannot bill for the visit until it is signed, and then that provider isn't going to, you're not able to bill for the visit, and there's a loss of money to the provider, that might be some incentive. Cassie, what else have you seen in that regard?
Right, yeah, no, you've already mentioned the vast majority of them. As far as a timeline, we don't have a hard and fast number. We generally see practices settle on somewhere around 72 hours for initially completing the progress notes and signing those off. And as Kathy mentioned, there really aren't any tools that we're aware of, but we have seen that the practice comes to a consensus that this is our procedure or our expectation for closing the note. And if there's not an ability to bill, I think that that is helpful sometimes for folks to understand that it's not, we can't submit it until it's signed off on, and that sometimes does help. Let's see, I'm not seeing any other questions just yet. Oh, let's see.
Insurance reps are now recommending to wait until the lab results are back to also include Category 2 codes. These take longer time to sign the notes because we have to update the diagnosis codes after the results are in. Again, I'm certainly not a billing and coding specialist. It
Mm-hmm.
sounds like you're getting the advice of someone who perhaps is. Um, you may want to do some investigation as to whether that note can be signed and then amended when the lab results come back, because in some cases if a lab is sent out to a reference laboratory, it could be several weeks before the results are back. So um, even even some pathology does not have a final result until several days or weeks have gone by. So you may want to really look into whether or not you can sign the note and then just amend it. Not seeing oh, there's another question it looks like. Uh, when records are requested by subpoena and no HIPAA authorization, should we just produce those records? Subpoenas are tricky. There's all sorts of different kinds of subpoenas. Um, and to answer that in a general, to give a general answer, I'm a little concerned about just being too overly generalized. It depends on what the record request is for, what type of subpoena, and whether or not it should require a HIPAA or whether or not a HIPAA authorization is required. Cassie, do you have any thoughts on that?
Yeah, I mean, this one, as you mentioned, is tricky, and we do have some blogs on our website about releasing for subpoena specifically. If you want to check that out, Rachel, I will say that sometimes we have seen false subpoenas or fake subpoenas, so you'll want to make sure that the document that you have is a legitimate document before just releasing. That would be the first step, I think. Again, we've seen some interesting ones that are not real. So I think that just err on the side of caution a little bit. And as Kathy mentioned, it is a little bit tricky, and without knowing the details, that would be a harder one to tackle.
It looks like that's the end of the questions, unless somebody's typing frantically, and I can't see that at this moment. But we appreciate your time and your effort. Please know that if you do have questions that come up after today's webinar, you can always email us at cyber@tmlt.org, and we will be happy to actually try to get you an answer at that point. If there are no other questions, we're going to give you a few minutes of your day back. And thank you for joining us, and hope to see you again next month for part 2.